Morning, Doctor. I'm Erina, and my other member is Sima and Anis. Today we're going to present the case study under clinical pathology. So this is our clinical history. A 61-year-old male with a past medical history of COPD, chronic obstructive pulmonary disorder, was recently admitted for left-sided pneumothorax, and he underwent a chest tube placement and pleurodesis and was discharged home. 3 days later, he returned to the emergency room with the shortness of breath, cough, and left-sided pleuritic chest pain. A CT scan of the chest showed a left upper loop lung consolidation consistent with a pneumonia, a moderate left pleural effusion, and giant bullous emphysema. So based on the case study, we suspected that the patient had a leukemia. So leukemia is actually a type of cancer that found in blood and bone marrow, which is caused by the rapid production of abnormal white blood cells. Leukemia can be either acute or chronic, and it also can be classified as lymphocytic or myelogenous. So leukemia had 4 types. First is acute lymphocytic leukemia, ALL, which is a condition where there's an overproduction of immature lymphocytes, which this condition known as lymphoblasts. Next, AML, acute myelogenous leukemia. This condition where a rapid growth of abnormal myeloid cells that accumulate in the bone marrow and blood. The next one is chronic lymphocytic leukemia, CLL, is a condition where accumulation of mature but incompetent lymphocytes, which is B cells, in the bone marrow, blood, and lymphoid tissues. And the last one is CML, chronic myelogenous leukemia. This is the uncontrolled proliferation of matured and maturing granulocyte, which is a type of white blood cells in the bone marrow and blood. So, based on the results of the patient's complete blood count and differential, it indicates a microcytic anemia with an absolute monocytic monocytosis and 28% of blast. Therefore, these results indicates that the patients had AML conditions, which is acute myeloid leukemia. So let's proceed for the subtypes and molecular level. So AML, acute myeloid leukemia, is actually known for its heterogeneity with various subtypes that exhibit the distinct morphological, immunophenotypic, and genetic features. So one of the foundational classification system for AML is the French American British FAB classification, which categorizes the AML based on the morphology of the leukemic cells and based on their degree of the maturation. So the FAB classification system established in 1970, and it classifies the AML into 8 subtypes, which is from M0 to M7, which based on the morphology and cytochemical staining of leukemic cells. So each subtype reflects a different stage of myeloid cell differential, which provide a framework to better understand the disease and guide the treatment decision. So as you can see, M0 is to under the category of undifferentiated acute myeloblastic leukemia. M1, acute myeloblastic leukemia with minimal maturation. M2, acute myeloblastic leukemia with a maturation. M3, acute promyelocytic leukemia APL. M4, acute myelomonocytic leukemia. M4, EOS, acute myelomonocytic leukemia with eosinophilia. M5, acute monocytic leukemia. M6, acute erythroid leukemia. M7, acute megakardioblastic leukemia. So next is for the molecular level. Each FFB subtypes can be further characterized by specific genetic mutations and cytogenetic abnormalities, which influence the prognosis and treatment progress. So under the molecular level, the FAB classification, we had first is run-related transcription factor 1 translocated to 1, which is actually common in M2 of M2 subtypes of AML. This translocation is associated with the relatively favorable prognosis. Second, we have promyelocytic leukemia or retinoic acid receptor alpha, AML-RARA. It's actually a hallmark of M3 subtypes, which is acute promyelocytic leukemia. And this translocation responds well to all trans-retinoic acid, or known as ATRA, and arsenic trioxide to transform the treatment approach and prognosis. And the next one is CBFB MY11 is actually a core binding factor that frequently seen in the M4 subtypes of AML, which is associated with a favorable response to the treatment. And the next one is internal tandem duplications in the FLT3 gene, which found in the various AML subtypes and are linked to a poor prognosis and aggressive disease. So the next one, we have nucleophosmin-1 mutations. Usually it's common across several AML subtypes, and these mutations are associated with a better prognosis in absence of the FLT3 genes internal tandem duplications. And other than that, we also have other mutations such as DNA methyltransferase 3 alpha, and also IDH1 or IDH2, which stands for isocitrate dehydrogenase 1 and 2, where it found in different types of FAB subtypes, and this mutation may affect the epigenetic regulation and cellular metabolism, which impact the disease progression and treatment outcomes. Okay, so next, the classification of AML subtypes has evolved over the years with the FAB classification system. However, this system was largely been supplanted by WHO classification, which incorporates genetic and molecular findings. So based on WHO classification, it's actually WHO classification system is actually more comprehensive, dividing the AML into several categories, which include first AML with recurrent genetics abnormalities. These subtypes are defined by a specific chromosomal translocation or gene mutation, such as the RUN-related transcription factor 1 translocated to 1, and also the core binding factor, and promyelocytic leukemia or retinoic acid receptor alpha. The second one, we have AML with myelodysplasia related changes, which characterized by the features of myelodysplastic syndrome, which also known as MDS. And the third one is therapy-related myeloid neoplasm. This associated with the previous chemotherapy or radiation therapy. And the last one, AML, not otherwise specified, or also known as NOS. This is a subtypes that do not fall into the other categories and are further classified based on the morphology characteristic, which is similar to the FAB systems. So for the molecular level insights, the AML is actually driven by a variety of genetic alterations, which include the point of mutations, chromosomal translocation, and epigenetic modifications. So these molecular changes may affect several pathways involved in cell proliferation, differentiation, and apoptosis. So the mutations commonly observed in AML, which include FLT gene, the mutations in FLT3 genes, particularly the internal tandem duplications, are found in approximately 30% of AML cases and are associated with a poor prognosis. So for the other one is NPM1. It's actually a mutation in NPM1 gene occur in about 30% of AML cases and are often associated with the prognosis in absence of FLT3 mutations just now. So next, we have mutations in DNMT3A gene, which stands for the DNA methyltransferase 3 alpha. This mutation in the gene, it involved in DNA methylation, which are found 20 to 30% of AML cases and are typically associated with adverse outcome. So the last one is IDH1 and IDH2. The mutation in this gene plays roles in cellular metabolism, which occur about 20% of AML cases and have a distinct implications for disease prognosis and treatment. And that's all from me. I'll pass to my friend.
So I'm Sima. I'll be explaining on further diagnosis method that I've done for this patient. So after FBC or complete blood count, we have found out that there are 28% of blood cells which supports AML. So we can do a peripheral blood film was done. So the finding was two plus anisocytosis, which is different sizes of blood cells. So microcytosis was done, which is why it was diagnosed as macrocytic anemia. So it could be possibly due to the ineffective erythropoiesis process. And then one class of poikilocytosis, which is different shapes of red blood cells, ovulocytes, and teardrops are found. This could also be due to the bone marrow stress or damage. And then one class of polychromasia could be due to the increased reticulocytes, which suggests also the anemia or bone marrow stress of the patient. So the image is here of the blood film, and then the white blood cells and platelet changes there were a lot of circulating blast, which is this black arrow is blood cells, and they are more than if it's a more than 20% of blast in peripheral blood film, it indicates AML, which is acute myelodysplastic leukemia. And then large giant platelets were also seen, which could be dysplasia in megakaryocytic lineage, suggesting myelodysplastic syndrome in this patient case. So other than AML are mostly related or commonly associated with patients that have a myelodysplastic syndrome or in the lineage of the myeloblastic lineage. So there's also bare nuclei or immature megakaryocytic precursor, which is this yellow color arrowed cells. These are immature platelet cells, you can say. So this is also due to the disrupted platelet production. In the higher magnification, the findings were the blast cell had higher nuclear cytoplasmic ratio, and then there were also fine nuclear chromatin and prominent nucleoli, which is abnormal. And then the platelet showed hypogranular, and it's also giant, which is immature and disrupted production. And then immature megakaryocyte nuclei was seen, which is also known as a turtle-like appearance. Then neutrophils were showed hypogranularity. This is also due to the disrupted production of neutrophils. But the monocyte and lymphocyte in the film showed no abnormality, which indicates that the monocyte and lymphocyte production lines are less affected, which also rules out lymphoblastic leukemia, as in the two main types of leukemia, which is myeloid lineage and lymphoblastic lineage. So the lymphocyte lineage is not affected. Only this myeloid lineage is affected. We can rule out that from this findings. And then nucleated RBC were also seen a few, which indicates some problem with the blood production or stress in bone marrow. So overall, from the PBF, we can see that myeloid progenitor cell lineage are affected, which is megakaryocytes and myeloblasts. Neutrophil were changed, and then there were monocytosis in the CBC also, which support the pneumonia infection in the patient. They presented with infection, which is common in AML also. So after blood, we will proceed with bone marrow because there were several blasts and myeloid lineage cells were seen. So by doing a bone marrow aspirate biopsy or smear, we can get a better understanding on what's happening in the production of blood. So in the bone manual differential count, less significantly high percentage of blast was seen, which is 46.3%, which is very high because a normal bone marrow should have only less than 5% of blast. So this supports the acute in the AML. And then with this finding, we can do a aspirate and biopsy because it is needed to have a detailed examination of individual cell morphology, including precise identification and characterization of blast, dysplastic changes, and also other cellular abnormalities that can be seen in aspirate. So from the bone aspirate, I included a comparison to see the differences of the cells that were presented in the case. So this is a picture of a normal bone marrow aspirate. You can see the cells are not a lot, like not crowded. But in this AML case, you can see there is hypercellularity. And in higher magnification, you can see more blast cells, this yellow color, arrow pointing on. And then green, you have maturing granulocytes, which is normal because it's a bone marrow aspirate. And then black also showed maturing erythroid cells. And then B and C, these two shows megakaryotic cells, which is platelet cells, immature platelet cells. It shows dysplastic and also small monolobulated and hypolobulated lobated megakaryocyte. It is a common finding of AML also when it's associated with megakaryocyte syndrome. Yeah. So as I've mentioned here, megakaryotic dysplasia is common in AML. Then when they are doing SPA, they will also usually do bone marrow biopsy, which was done in this patient. So it is usually done to confirm for several reasons. First is to confirm diagnosis, where the biopsy can corroborate the percentage of blast and the presence of dysplastic cells observed in the aspirate. So they have seen a few changes in the aspirate, but they wanted to see the percentage, like how many percentage of the total cells in the bone marrow are affected. And then they can also assess the overall marrow, like the bone marrow density or cellularity in the context of the patient's age. As we can see here, according to the patient age, hypercellularity of 50 to 60% are found for this patient. And then they can also do a differential diagnosis among marrow fibrosis, granuloma, necrosis, and focal lesion, which will significantly affect the treatment decision. And then they can also do additional tests like IHC to characterize the cell population and also support diagnosis. And also CD61 and CD117 staining can be done in ICC or IHC to confirm the blast population and distribution in the marrow. So this is a zoomed in, increased magnification of the biopsy. The blue color arrow shows blast cells, and also the yellow color arrow shows dysplastic megakaryocytes, also monolobulated and hypolobulated, which was already seen in the aspirate, bone marrow aspirate. So for additional tests, there were iron stain, ICC and IHC was done. So iron stain showed high iron storage and also rare in sideroblast. And then the immunocytochemistry stain showed megakaryocytes and also mononuclear cells. Moving on, the IHC, which is a CD61 marker, showed a weak to moderate intensity for megakaryocytes and also strong staining for factor 8, which is used to identify megakaryocytes. So this marker is actually a protein expressed in megakaryocytes and platelets, which and also in myeloid lineage precursor cells. So from this additional test, we can scope down the AML into its subtypes on specific types or strains of AML. So in this case, a lot of megakaryocytes changes and markers were expressed. So it could be an AML with myelodysplasia related changes according to this finding. But further tests are supposedly needed, and which was also done for this patient to specify the genetic mutation and subtypes of AML, which will present by Anis after me to scope down or rule out our AML diagnosis. Thank you. That is all from me.
Hi, my name is Nur Anis Najia binti Ramli. So I will explain about the cytometric studies. So the flow cytometric studies performed on the spread show myeloblast population comprising of 51% of total NS cell with phenotype of this following phenotype. And in addition, they also have few granulocytes and 5.2% of CD14 plus monocytes, few heterogeneous T cells, and also few polytypic B cells. So this is the findings from the cytometric studies. So first is high percentage of myeloblasts. So they have 51% of myeloblasts. So a high proportion of immature myeloid cells is the primary diagnostic criteria for AML. And the diagnosis of AML is considered when the blast count is 20% or more of the total nucleated cells in the bone marrow or the peripheral blood. The second one is markers indicative of immaturity. So the CD34 plus and CD117 plus are commonly expressed on hematopoietic stem and progenitor cells, which indicate an immature myeloid population. And also CD45, also known as leukocyte common antigen, often expressed at lower intensity on immature myeloid cells compared to mature leukocytes. The third one is myeloid lineage markers. So the CD13 plus and CD33 plus are myeloid antigens, which are found on myeloid precursors and also strongly associated with a myeloid lineage cells. And the HLA-DR class, which also known as MHC class 2 cell surface receptor, which often positive in myeloblasts. And the aberrant expression, the expression of CD7, CD56, CD4, CD3A, and also CD36, which are not typically found on normal myeloblasts, and also suggest the aberrant antigen expression, which is common in AML. The next one is the absence of differentiation markers, which include the CD64 minus, CD40 minus, CD15 minus, CD16 minus, and also CD11B largely. So the absence of these markers indicates that the cells are not mature into monocytic, granulocytic, or other more differentiated myeloid cells. And the TDT and also MPO, so the TDT is a marker of lymphoid precursors, and its absence supports a myeloid rather than lymphoid lineage. And the MPO negativity can occur in some AML subtypes, but it's also seen in a certain early precursor stages. And next is absence of megakaryotic markers, which are the CD41 largely and CD16 largely. So this excludes a megakaryoblast lineage, which support the diagnosis of AML rather than acute megakaryoblast leukemia. And the last one is the additional of cells population. So they have few granulocytes and 5.2% of CD14 plus monocytes. So the presence of these few granulocytes and also monocytes indicate some preserved differentiation capacity, but is overshadowed by the predominance of myeloblasts. And also they have few heterogeneous T cells and polytypic B cells, which the presence of normal lymphocytes in low number is typical in bone marrow samples, which indicate these are not part of the malignant population. The next one is cytogenetic studies. So the fluorescence in situ hybridization, the FISH studies were negative for the BCR-ABL1 gene rearrangement in all 269 interface cells at the main. So for the BCR-ABL1 gene rearrangement, so the BCR-ABL1 fusion gene, also known as Philadelphia chromosome, is a specific genetic abnormality that is commonly associated with CML, and it is also present in a subset of ALL cases. So the presence of this gene rearrangement typically indicates that this type of leukemia rather than AML. So this is the difference between the AML from CML and ALL. So for CML, nearly all cases of CML characterized by the presence of this gene rearrangement. So a positive FISH test for BCR-ABL1 is a hallmark for diagnosing of CML. For ALL, some cases of ALL also show the BCR-ABL1 rearrangement, although it is less common compared to CML. But for AML, does not typically involve the BCR or ABL1 gene rearrangement. So therefore, a negative FISH result for BCR-ABL1 in the context of leukemia symptoms and other diagnostic criteria support the diagnosis of AML. So that's all for my part. Thank you.